Good day, good afternoon, everybody. It's Johnny Curry, one of the co-directors of the 19 Hills CIC, here today with Dr. Sally Lewis. Hello, Sally.
Hi, Johnny. Good to see you again.
Sally and I were just touching on, I suppose, our kind of potted history since we met several years ago. And before I do that, I should welcome everybody to another episode of the Community Health and Capital podcast, affiliated with 19 Hills Community Interest Company. If you're listening to this for the first time, we run a podcast talking about integrated services, preventive services, public health policy. It's a broad church. Sally, so we first met. I know we've got lots of interesting things to talk about, including the fact that you've got a new book coming out, which is really exciting. Congratulations.
Yeah.
But I was taking us back a second ago, wasn't I, to when we first met, which I think was in the offices of Welsh Government back in 2019, in a different world, a different place. Just lead us through what you were doing at the time then, and how you found that role.
So 2019 feels like 100 years ago, doesn't it? Because it was pre-COVID, pre-pandemic, and it does feel like a black hole, that whole period of time as the pandemic. So it does feel like a very long time ago. But in 2019, I was about a year into my role as the Director of Value-Based Healthcare in Welsh Government for Wales, and on a journey to establish the Welsh Value and Health Centre. And why? You might ask. Well, if you remember, Johnny, we'd been doing some work for a few years before that in one of the Welsh health boards on implementing value-based healthcare in our integrated healthcare organisation. And that was really born out of a realization that we needed radical healthcare transformation if we were going to meet the needs of our population and our patients as general practitioners, as we both are. And that for me, value-based healthcare, because it has this focus on outcomes that matter to people, and also a focus on how we make the best use of our resources across a whole pathway of care, from prevention through to end of life, that this is a really good way to achieve that radical transformation that we need, and that everybody finds so difficult. So that I was just in the throes of that, I think, in 2019, and still quite in the early stages of it when we first met.
And probably for the sake of my career, and certainly both of ours, really, we probably should leave less comment on a kind of a experience of Welsh Government at the time, really. But it was an interesting time, wasn't it? Kind of leading straight into what do we do from a data perspective in terms of kind of planning and responding to the COVID emergency.
Yes, absolutely. And I think one of the challenges that I was experiencing pre-COVID actually was around access to data that could support operational decision making that went beyond the traditional metrics of length of stay in hospital or waiting times for outpatient clinic, but really getting access to outcome data for patients so that we could understand where there were some unmet needs in our community and how we might start to tackle that. And I think if there was a silver lining to the pandemic, it was that there was an acceleration of work done to improve access to data to support that kind of decision making. So, for example, I had quite a lot to do with the vaccine campaign in Wales, and we had very good data to show uptake of vaccine, and really understand from an operational perspective where we were not achieving our kind of vaccination, and how we could redesign services in a very agile way to meet the needs of populations who were not able to access the vaccine in the standard way. So for me, that was a really good example of how certain types of data need to be brought much closer to operational decision making. And then that played out, didn't it, a little bit with outcome data when we started to see some of the impacts of the pandemic.
It was just a memory I'll never really forget, really, which I think is that kind of moment around early first wave, early 2020. I suppose how unsurprisingly possessive people are about data and their data, but also sometimes their role in that data. And I'm sure you won't have forgotten, we had, a UK level, the kind of initial, we're trying to figure out how this is going to work and how it's going to impact on people, colleagues across the country, even in England and also in devolved nations in Wales and Scotland, couldn't see access to that modelling really. And it was all, as you
Mm.
talked about, folks in hospital. And then we had us in Wales going, right, it's on us maybe a little bit really. How do we use the data creatively? And you had colleagues in public health saying, well, that's normally our role. Nobody else should be doing that. And you had people in, I think it was still possibly NWS at the time, or it was Digital Healthcare Wales going, but we can do it. And actually we've got the data too. Um, and it's so important, isn't it? The cultural, the politics, the personalities. It's often some of these things that get in the way of doing good, making good things happen and data sharing.
Yeah, I mean, I completely agree with that. I mean, I think reflecting, if we put aside information governance for a moment, because clearly we need to abide by, rigorous information governance rules, but beyond that, if there's one thing I've learned is that collaboration generates much better insights into what's going on in our healthcare systems. Rather than people trying to look at data in silos, because we all bring different skills and different perspectives to the table. So collaboration between different organisations who might not normally collaborate generates those real insights. And I think the COVID pandemic was a really good example of why that is so. But also since the pandemic, as we start to deal with some of the fallout really for outcomes for non-COVID reasons, we can see that sort of collaborative insight has been necessary to tackle some of those issues too. And that includes things like things that are in the newspapers a lot, like long ambulance queues outside the ED, for example. Understanding what's driving that requires collaboration across many sectors, not just those involved in urgent care, but also, as you very well know, people working in the community sector, palliative care, and so on.
And I suppose we've started the podcast, haven't we, with kind of, where we met and kind of where our paths crossed. Just give us a little bit of a background, if you can, Sally, on kind of, where things started for you professionally and how you happened across this beast called value-based healthcare.
Well, I'm a general practitioner by background. I trained on the south coast of England, and I was a partner in Bournemouth for 7 years before moving back to Wales, and joining a practice in Ebervale in the South Wales Valleys, which had significant challenges in delivering care to its population. And I think it was the first time that I'd really been exposed to the effects of the inverse care law. So the inverse care law, as you know, described by Julian Tudor Hart, in that people who most need care might have least access to it. And I'd not really felt that personally until I came back to South Wales. And I realised that actually this isn't a problem of individual practitioners. This is a structural problem, because we tend to, in healthcare, spread everything equally, don't we? We spread the jam equally across the piece of toast, whereas for those in greater need, of course, they need disproportionate investment to enable them to have the best chance of achieving the same outcomes as others. So it was in that environment that I was frustrated at why we still have this structural problem, more than 50 years after the inverse care law was described. And that's what got me into value-based healthcare, because I thought, well, when I came across it, I thought, wow, we don't actually measure outcomes that matter to people really, other than what we put into clinical audit, and that comes at us late, a year down the line in a report. We're not using outcome data from patients to drive our decision making around how we allocate resources and to assess ourselves on a rolling basis about whether we're achieving what we need to achieve in healthcare. So that was a bit of a gut punch for me when I kind of realized that, and that's how I got into this whole business of value-based healthcare, to try to help us gain some tools to achieve the healthcare transformation that we need to achieve. Also to reduce inequalities in health as part of that.
Mm. More fortunate, I suppose, really. I mean, some of us can be too easy to kind of quickly criticize what it is that's going on. But when you compare our health system to many others, I suppose being both GPs, we have to credit the fact that, that kind of GP is a gatekeeper service, whether you like it or loathe it, has an impact on holding back people from getting expensive, specialized, highly technological healthcare at times, especially the more you invest in it too. But I suppose we also have kind of health technology, National Institute of Clinical Care Excellence type bodies too, which must have a role in making the health system more value-based in extent, do you think?
Oh, yes, absolutely. And I think that, look, I'm really lucky now. I get the opportunity to work internationally with a number of healthcare systems. And what I can say with absolute certainty is that no healthcare system in the world is perfect, and none is immune from this perfect storm that we're all feeling at the moment, which is that we have rising costs, we have a workforce crisis. We're not going to have enough healthcare professionals to look after us if we carry on in a similar vein. And we've got this huge burden of people living with chronic disease for a very long period of time who need to be supported. So we all need to do things differently. And the great thing about the NHS is that it has had equity at its core, and it does many things very, very well. And there's a lot of transparency because there's a unique patient identifier, so we know what's happening to people, sort of, and we know when people have difficulty accessing care. In other systems, it can be a little bit more opaque, that inequality of access to health. And yeah, you might not have quite so much transparency around the pressure that the system is under. But believe you me, every system is under huge pressure, and that is going to always result in difficult choices having to be made about how we resource things, and whether we resource things. So in answer to your question about the adoption of new technologies and health technology assessment, absolutely, we need that evidence-based approach to the adoption of new technologies. However, we also need to remember that randomized control trials, for example, are done on ideal populations, aren't they? So when we adopt new technologies, sometimes very expensive new technologies, we then extrapolate them to people who would have been excluded from those trials. So we don't really know in the real world what outcomes we're going to get for that technology. So I think we have a duty to continue to collect outcome data once things have entered the market as a sort of post-adoption strategy, so that we can ensure we're getting really good value from those things. And then I think there's another scenario where we're needing to rapidly innovate our care models and care processes, sometimes supported by digital technologies. And the traditional evaluation methods don't necessarily lend themselves very well to that type of agile working. It's also very expensive. So we need to evolve our evaluation methods, I think, particularly around that care process innovation, so that we can start to make better use of the workforce, better use of digital technologies, and understand on a much more rolling basis what's going on.
Mm. And I'm sure before we get too much in the nuts and bolts of all of that, it's a good time to bring in your new book, I suppose, Sally, which is implementing value-based healthcare, an insider's guide to improving patient outcomes and creating scalable systems, which I'm sure touches on lots of the messages you started to articulate there. Just leads us and listeners through, when you started to think about this book. Why did you write it?
Well, I think I started thinking about it probably about 10 years ago, fairly early on, because uh, I was working with my colleague Adele Carhill when we were together in the Aneurin Bevan Health Board in South East Wales, and we realised that we were really learning very fast on the job, and that other people might benefit from the mistakes that we were making, basically. So we ought to maybe write it down. um, and of course, life takes over and work takes over, and you don't have time to write things down. So the years went by and the learning continued. And then last year, when I left the NHS, I had a little bit of time and headspace to think about writing it again, and that's what I decided to do. So the book is part it's partly a description of the journey that we were on in Wales as we explored the implementation of value-based healthcare, both at a local level and then at a national level. And then the rest of the book really tries to simplify and break down what the building blocks of value-based healthcare might be, and just help people navigate their way through that, because as you know, it's a huge topic, and healthcare transformation is a big complex beast. So I've done my best to break it down into chunks.
And I can recall seeing little snippets on social media of your kind of reflections along the way of writing it, and I suppose that, I'm making some assumptions, but it's a fast paced but also a little bit of a volatile space. This kind of disruption and innovation, and sometimes that can come with a few bruises, dare I say, scars. I guess really. What was it like to write the book after all these years? How did it feel?
Yeah, I mean, it certainly did come with some bruises and scars. And over the years, I used social media, especially Twitter, back in the day when it was a little bit more functional, um, to test ideas, because I'm not a writer at all. So um, I found doing little tweets quite a helpful way to crystallize my own thoughts on the topic, and
Mhm,
also test ideas
mhm,
with
mhm,
with the wider community. And Twitter back in the day, I think, was really useful because it was very democratic. So you could be having a conversation with a patient or their relative, or
mm.
another GP or a policymaker. Everybody was in that mix, and I found that really, really helpful in terms of developing ideas and crystallizing my own thoughts. And over the years, wrote down lots of these scraps and insights, and so writing the book was quite a lot of it was bringing together stuff that I'd already written down in a scrappy way over the years.
Interesting. Maybe a country like Wales needs its own professional public social media platform. I just wondered amongst the book then. I mean, there's a big question of why. Why doesn't this happen? What gets in the way of this kind of beautiful, utopian view of a public taxpayer-funded system that has scarce resources and has to be, in theory, distributed appropriately and sensibly and fairly. What are the big things that gets in the way of that, in your view?
Hmm. Um, well, I think obviously culture is really, really important, and a willingness to change, because change is hard. It doesn't matter if it's change for the good. Nobody really likes change because it's work and it's disruptive, and somebody always is like less benefited, shall we say, from any change than somebody else. So there will always be issues of vested interest and people wanting to keep the status quo the same because it's more comfortable for them. So really big change is a long-term endeavour, and my reflection is you have to spend a lot of time building relationships, de-risking it for people, and making people see, what's in it for them, essentially, in terms of that large scale change. I also think there are certain things about structures within healthcare system that people are not necessarily aware of. So for example, we've all grown up in the NHS, so we make a lot of assumptions about the way it's run and the way it's structured, and that it has to be like that. So I remember a paper that you wrote not so long ago, Johnny, around the financing of general practice, for example, and how that had evolved over the years. And we take that as read, don't we? We take it as received wisdom because that's how it was done. Doesn't mean it has to be done that way. And there are many other places in the world that do it differently, and some of them do it better. So what I'm getting around to saying is we need to always be prepared to be self-critical, and really to examine and question everything that is going on in the system that is leading us to where we're currently at. So, and not making the assumption it's necessarily the right way to do things. And that's why I think value-based healthcare is such a helpful lens through which we can look at the system, because it just keeps bringing you back to, are we achieving the outcomes for people? And if the answer is no, we have to ask ourselves why, and then examine all of our structures to see to what extent that is contributing to the fact that we're not achieving the best outcomes that we could. So if there is a structural problem with the way we finance primary care in the UK, then we need to be humble enough to say we have a structural problem with the way we finance, and then do something about it. But it starts with that, the willingness to question, I think.
And I suppose, I was speaking to a colleague earlier who, somewhat on that point, was saying he just wishes we could encourage everybody, or as many people as possible, to develop systems thinking, just to be able to think about different systems and different organizations, and a broader kind of perspective. And I suppose on that point, culture is a bit received. You inherit patterns of behavior and patterns of thinking from other people around you, but culture is also somewhat taught in the assumptions that people receive through the education and the teaching and the training and the mentoring. How much do you feel we are encouraging people in all professional groups? Because we're talking about professional culture, of course, really, aren't we? How much do you feel we are teaching and training people from this point onwards in that kind of patterns of thinking and models like value-based healthcare?
I think we have a way to go. I do think we've come a long way in Wales in terms of multi-professional learning. For example, through the Value-Based Health and Care Academy at Swansea University, all of the courses, which I am now a part of, encourage multi-professional learning. So bringing together clinicians, managers, accountants to do that problem solving together. And one of the big lessons for me over the last 7 or 8 years has been the need to step outside one's tribe and get that different perspective, just as with the data issue that we talked about earlier. Because once you start to sort of walk in somebody else's shoes, you can understand their behaviour and why they make the decisions they do, and the pressures that they feel in their own day-to-day work. But the system doesn't really encourage us to do that. The system has targets and expectations of different professional groups, which they have to adhere to. Systems thinking is critical. I think it's probably too much to expect everybody to have a systems approach. If I could turn it around the other way, for example, I'm not a detail person. If you put me in an analyst role, I'd be daydreaming, and it would just not suit me to be down at that level of detail. It'd be a disaster. And so similarly, others may not feel comfortable or want to be moving around and thinking about the system from a broader perspective. So I think we need to play to our strengths. But I do think that there needs to be um, a systems approach when we're thinking about tackling the problems of healthcare at the moment, because healthcare on its own cannot solve its own problems by itself. We need to be working with other sectors, in the community, very much as described in the Wellbeing of Future Generations Act that we've got in Wales, which is a brilliant piece of legislation. We just haven't quite got there in terms of its full execution, but I'm still optimistic that we will.
It's very generously put. If systems thinking and value-based healthcare is everybody's business, what would you say might the role be for patients and the public in it then?
That's a really interesting question. So, to my surprise, both locally and nationally, when we started to engage both individual patients in a service, but also patient organisations and the wider public in value-based healthcare, what they all said to me, and I don't think there was even an exception. They all said, "Well, aren't you doing that anyway? Aren't you focusing on outcomes, and aren't you making the best use of resources anyway? We would expect that." And so it was a bit embarrassing to say to them,
Mm, mm,
actually, no, that's
mm.
not how decisions are made in the healthcare system, not just in the UK, everywhere, pretty much. So they are, in my experience, the biggest champions of this. And of course, particularly in relation to how that makes them feel in any sort of healthcare interaction, whether somebody's actually asked them, what are the outcomes that matter to you? Because it does play out at that individual shared decision making in a consultation level, as well as at a sort of macro level that we've been focusing on so far.
Fascinating. Well, I suppose as we start to run up, Sally, I just wonder if you could talk us through, what could people learn more about if they read your book? And if I could get a two-part question in there too, what are some of the promising things you've happened to be able to kind of see or immerse yourself in internationally? Because there must be so many interesting voices, perspectives, approaches that we don't always take on in the UK, do we?
No, we don't. Okay, let's start with the book. So I think it's a short book. It's easy to read. It's not an academic tome. It fits through your letterbox, and it's a summary of all the learning around cultural change management, loads of stories, examples of amazing clinical teams who've done great work, both to redesign care and improve outcomes. And it finishes off with a chapter on, what next and how we continue to drive this forward in Wales and internationally. So I hope people find it just a useful and hopefully moderately interesting read as well.
I'm sure they will.
Um,
I'm sure they will. I'm looking forward to my copy arriving.
and then in terms of the international perspective, I think what's been really striking to me is each country has gone on this value-based healthcare journey on its own. pretty much. And it has taken the principles of value-based healthcare, so improving outcomes that matter, looking at resourcing and measuring that, and using that to drive decision making. And they have pretty much all arrived at a similar framework, a similar conceptual framework around how they implement this, how they drive this forward in their own country. So even in Saudi Arabia, where you might think, gosh, what would the similarities be between Saudi Arabia and Wales? Actually, the principles are exactly the same, and the way the Saudi Value and Health Centre has gone about driving forward in improving value in Saudi Arabian health, it's identical. And similarly in Singapore and in Canada and in Europe. So I think the similarities are greater than the differences, interestingly, internationally. But I do think we have a lot to learn from where people have made really smart investments into the health of patients that is making a very big difference. And we struggle to do that at the moment in Wales because we are in such a cash-strapped environment. But the example I want to share with you, Johnny, which I know will be close to your heart, is I went to a large primary care centre a few weeks ago in Singapore, and they had been very systematic about how they support patient self-management in chronic disease, such that they had a digital inclusion station. So they would coach people in how to use digital tools to support the management of hypertension and diabetes on their smartphone. They had the technology there for people to do the monitoring, whether it was of their blood glucose or monitors for blood pressure and so on. But they had thought about everything and been totally systematic about it, and that was having really profound effects on the chronic disease management in that community. Now, we know we need to do that in Wales, but often I think because it takes a little bit of upfront investment, lag behind in that really, that community asset-based approach to doing things. And that's where we need to get to, and where I think we can learn from some of the interventions in other countries.
Fascinating. And I mean, of course, innovation is contextual, isn't it, really? And I think we
Yeah.
do suffer sometimes from going, well, why can't we just import this fantastic, piece of work or this fantastic approach that's been done in X, Y, or Z country or community? But there's something to be said for the kind of the febrile, somewhat divisive times that we live in just now, kind of, nationally, internationally, that, there's still that potential for hugely valuable collaboration and seeding of ideas and recognizing that globalization has always benefited us, I suppose,
Yeah.
really. But we're nearly running out of time. But if I'm just pushing it maybe a little bit, I'd be really intrigued because we are in Wales coming up to election season. What might you be hoping to see in the next kind of 12 to 18 months if we talk about Wales and the UK, and kind of where do we go from here?
Well, gosh, I would have a very long wish list, but I'm going to pick one thing. So, data transparency drives behaviour. And I think we need to be very bold about putting in a more public domain our outcome data, all of our data actually in relation to healthcare, so that we are improving in plain sight. I don't think we should be shying away from that, because I know, based on my days in general practice, for example, when you remember we have prescribing data, very, very public, and you see the variation in prescribing data, and we see the response of practices to changing prescribing behaviour as a result of that. Imagine if we did that with outcome data, the system would respond because people respond to to seeing data like that. And that's the biggest incentive of all. So that would be that would be top of my wish list, because everything would flow from that, including investment in prevention.
So whoever leads us over the line in May 2026 in Wales, really, you heard it from Professor Lewis where we need to go. Well, Sally, it's been a great privilege to spend the time with you this lunchtime. Just sharing your insights. You're fantastically interesting, and inspiring career too. And I am really looking forward to telling colleagues about this book and reading it too. And we'd love to have you back on the podcast to talk about what next, because you're clearly going on to even better and greater things. So thank you so much for sharing some of that with us today.
Thanks, Johnny. It's been my pleasure. Really great to see you again.
For everybody finishing the podcast just now, this has been another episode of the Community Health and Capital podcast, live with Professor Sally Lewis here on Database Healthcare. If you've got an interesting topic or want to go on a podcast, please drop us a line at info@19hills.org, and we look forward to hearing from you more. We're putting out podcasts around about every month, covering topics from public health, primary care, innovation, and we'd love to get more people from the third and community sector. And we look forward to updating more. Thank you again, Sally. We look forward to speaking to you soon, and we'll catch up soon.